Good morning, everyone. A big thank you to Dr. Shona Nag and Dr. Sudeep Gupta for the invitation, respected chairpersons, and my friends, colleagues, seniors. So, as we continue on the discussion for local regional therapy, there are two abstracts I'm presenting today. The first one is about the IDEA trial. The IDEA trial was basically a single-arm cohort trial, a prospective study. So, you get to the background of why they started this study. We know that we are in the era of de-escalation, and everybody is trying to now do less for surgery, radiation, as well as for the primary, as well as for the axilla. So the idea came from omission of RT in older women, more than 70 years of age. And this was seen in a couple of trials where the local regional recurrence risk was around 10% when radiation was omitted in favorable tumors. But even if you look at the data in those trials, when radiation was added, the chances of recurrence came down from 10% to 2%, which is not something which is discussed. They took the 10% and went with it, saying that this is a low enough number and we can accept it for avoiding radiation. But yes, there is a definite role for reducing the side effect profile, the cost and the duration of treatment that these early cancer patients face. We now know that genomic risk scores are well established in avoidance of chemotherapy. We know that they can be used to predict the outcomes in chemotherapy, and certain group of patients can be avoided. So omission of RT in a certain group of patients, especially in the younger postmenopausal women, has not been explored too well, and there have been previous studies, older ones, which have shown a higher recurrence risk. So the trial design was again very, very specific, where they took only T1N0 patients. They did permit isolated tumor cells in the axilla, but only one patient in the trial had that. They accepted margins more than 2 millimeters. They also had to be strongly ER and PR positive. They took the oncotype DS score arbitrarily at 18. They don't really explain why they took 18 as a score, but that's what they have selected. And they've said that below 18, we'll go ahead with avoiding radiation. And they gave the patients 5 years of endocrine therapy. Again, possibly because at the time 10 years was not a standard of care. Their endpoint was primary endpoint was the local regional recurrence at 5 years. Exclusion criteria was standard for avoiding radiation to these patients. They enrolled about 200 patients. They had 186 with a good follow-up, so very small loss to follow-up. The age was around 62, which is a good number considering the previous trials had a 70-plus age group. And their mean oncotype score was 11, which is again actually a very low risk score. This is the main thing that always strikes us, and especially in the Indian scenario, that the mean tumor size is 1 centimeter and barely any grade 3 patients. So even though they didn't have a Ki67 inclusion criteria, but somehow all patients were grade 1 to grade 2. As we can expect for this subgroup of patients, their overall survival was 100%. So none of the patients had any death due to breast cancer. And the recurrence rates were around 3.3% in the younger patients, and in the slightly older group, 3.6%. Again, something which you would expect in this group of patients. So as we can see that the risk of recurrence is very low using these criteria. We need to understand where longer endocrine therapy was used. So maybe the risk of recurrence might be even lower. They came on the oncotype DX as a score because the previous trials had shown, retrospective analysis had shown that oncotype DX is also predictive of the recurrence in these patients and local recurrence, not just distance. So they say that these efforts will help make the patient, empower the patient to take a decision, a clinically meaningful decision in their own therapy, and we can give them an option. The comments on this trial, so they had a relatively small sample size. It was a single-arm study, and the inclusion criteria are extremely specific. There is a lot of further randomized data coming on this topic, so that may help form future guidelines. Radiation is much safer than before. I'm sure that whole breast radiation or chest wall radiation is much better today. There's a lot of data coming in for fast forward, which is a 5-day radiation, a simultaneous boost therapy. So radiation techniques have also evolved to reduce the side effects and reduce the treatment time. So this is going to compete with not giving radiation, which is going to be difficult to prove in the future. Lot of trials now going on, and hopefully in the next few years we'll get some answers in randomized trials. In Indian scenario, again, very difficult. Oncotype DX today still stands at more than 2.5 lakhs. It's very difficult to offer it to a majority of our patients. And we don't know, there's no randomized data to support using Oncotype DX just to avoid radiation. We have the data to say that yes, for chemotherapy we use it, but for radiation it's still not there. We don't have the validity for using this in Indian patients as of now unless somebody takes it ahead in India. And we know that Indian patients have a poor compliance, they have a poor follow-up. So you have to weigh the benefits of giving RT to such patients and versus not giving them. And the number of patients with a 1 centimeter tumor are anyways quite few. We'll go on to the next abstract. So this was a fresh take on developing a new genomic profile in the omission of local RT. So as we discussed in the previous abstract, we have this 10% local recurrence rate in older postmenopausal patients. They are using genomic risk stratifiers to decide regarding chemotherapy and now also radiation. But there is no specific genomic signature for radiation alone. All that we are doing is extrapolating from the chemotherapy arms. This group that published this article had also developed a score previously to predict the benefit from radiation, but they did not use it to prognosticate. So what they did is they went back, they had published this trial, the Swedish BCG 91 RT trial, which was a patient group of around 1,178 patients. Now, ironically, in this group, in this trial, they said there is no population in breast cancer or early breast cancer which can actually avoid radiation because they saw a local recurrence rate of 23% when they avoided radiation. So it's quite, the authors going back and analyzing their data and taking the genomic score out of it is quite forward thinking. So these patients had standard treatment given to at that time. There was another study which they took, which was the Princeton-Margaret study. They had a lot of tissue from these patients, which is the importance of tissue banking, and then they went ahead and did a genomic analysis on it. So they developed their own recurrence score, which is this polar. Like we have the oncotype, this is the new recurrence score which they came up with after analyzing the genes that were seen to be coming positive. So they had a positive and a negative panel, and then they compared that with the outcomes of those trials. So the primary endpoint was again the local recurrence. They haven't mentioned how they categorize low risk and high risk, but they had a very good correlation when they saw the low risk versus the high risk. The low risk patients, they did not have any benefit with radiotherapy at 10 years also. So they had just a 6% recurrence rate, which is quite less. And at the same time, the high risk patients, they had a 19 versus 8% recurrence rate in the local regional recurrence. So this is quite a significant outcome if you look at the numbers they have studied and going back and looking at the score. So this, they have said, is the first molecular signature dedicated to radiotherapy. And considering the previous molecular signatures that are being used, such as oncotype and MammaPrint, they say that there's only one gene which is overlapping with these two signatures. So possibly this may give us some new information and which is not there with us with using oncotype and MammaPrint. So considering that this may be a new genomic signature which might add, rather than just give some same outcomes, we can actually add some information and possibly give us new information to take a decision. So coming to the comments, it's definitely a promising genomic score which can be explored further, but it needs extensive study in phase 3 trials and especially in randomized study in going ahead. It may be difficult for them to do this because there's a lot of data coming out with the currently available genomic scores. So them to compete with something like oncotype, which is established for a long time now, is going to be difficult. And people to accept this score and take it ahead, again, is going to be a difficult thing for the authors to actually probably go ahead with. Since this was a retrospective study, there definitely were a lot of confounding factors. These studies were performed 20 years back, and the data was published in the last decade. So definitely a lot of old data, and the patient treatments were also, for example, the Swedish trial had all patients going for axillary node dissection. So possibly that's not something that we see today. We see a lot of sentinel node biopsy. So definitely different factors which are going to influence the outcomes in these patients. Thank you. Thank you for your patient listening.